Welcome to the presentation for Module 5 for Nursing 150 regarding disorders of the patient in the upper GI tract. And again, that's Module 5, not Module 4. The first disorder we'll discuss for this presentation is gastroesophageal reflux disease. It's one of the most common upper GI disorders in the United States. It results as a backward flow of stomach content into the esophagus. Typically, it's in relation to a poor lower esophageal sphincter. The function of the sphincter is supposed to prevent the backflow of the gastric content into the esophagus. GERD is a result of an excessive relaxation of the lower esophageal sphincter. It allows this gastric content into the esophagus and exposes the esophageal mucosa to this acidic gastric contents. Patients who are overweight are at high risk for developing GERD because the increased weight increases the intra-abdominal pressure, which contributes to that pressure pushing the lower esophageal sphincter open. Nighttime reflux happens for people because of the way when they lay flat. That allows that sphincter to open. Hiatal hernias are also related to the development of GERD, and we'll talk about what hiatal hernias are in the next few slides. Helicobacter pylori, H. pylori may also contribute to reflux, causing a gastritis, and we'll talk about that in the next few slides as well. Other factors that can contribute is large meals. All of the foods and things listed here are also that can contribute to the signs and symptoms of gastroesophageal reflux disease. They cause gastric distension, bloating, which can increase the pressure and cause the lower esophageal sphincter to not do what it's supposed to do, stay closed. Typically, they have signs and symptoms. They have dyspepsia, which means indigestion, regurg, where the backflow of the gastric content goes back up into the esophagus. It can go up as high as the throat, too, which can cause coughing and hoarseness or wheezing at night. They can aspirate it. They can get it into their lung, especially if this regurg is happening at night when they're laying flat. They can have dysphagia, painful swallowing, which is odonophagia, epigastric pain, belching, heartburn, that epigastric pain there that is sometimes referred to as heartburn because it's near where the heart is. Typically it occurs about 20 minutes after a meal, 20 minutes to 2 hours after a meal. It's because of that pressure that builds up, and then it starts the release of the gastric content after you eat. Really not any diagnostic tools other than sometimes they'll go ahead and treat them with medications appropriate for GERD if they have the signs and symptoms of GERD and all the risk factors. They'll treat them possibly with maybe a proton pump inhibitor. If that isn't effective, then they might do a barium swallow, which could show if there's something more serious as far as maybe a hiatal hernia or stricture or some kind of anatomic esophageal problem. If that is inconclusive, they might also go to an EGD, which is taking that scope down and taking a look at the esophagus itself and see what's causing the patient to have the symptoms. Treatment for GERD is typically non-pharmacologic interventions initially, such as nutrition. So avoid all of these things that can exacerbate it, as far as caffeine, spicy foods, tobacco, and alcohol products. Tell them to eat small, frequent meals. They might have to see a dietitian to help them with this. Lose weight, exercise more, lifestyle changes like that can help. They might have to elevate the head of their bed 6 to 12 inches so that when they lay down, they're not flat, which will decrease the symptoms of it. There's a good table in your book that talks about health promotion and lifestyle changes to control reflux. Eat 4 to 6 meals a day, limit or eliminate fatty foods. Do not wear constrictive clothing. If you're overweight, lose weight. Remain upright for 1 to 2 hours after meal. So don't eat late at night and then lay down right away. Things like that. Drug therapy for GERD includes 3 major types: antacids, histamine blockers, and proton pump inhibitors. They are used for peptic ulcer disease as well, and you'll hear these drugs over and over again as we talk about the disorders of the GI tract. Histamine receptor antagonists, also known as histamine blockers, such as famotidine, ranitidine, are pretty safe drugs. They are over-the-counter available. They basically reduce gastric acid secretion and promote healing of the inflamed esophageal tissue. Proton pump inhibitors such as omeprazole, pantoprazole, which is Protonix, Prilosec. They're the main treatment for a more severe GERD. Proton pump inhibitors are available over the counter as well. These have long-acting inhibition of gastric acid secretion by affecting the proton pump of the gastric parietal cells. They reduce gastric secretion, can be given in a daily dose, but they are not for long-term use. They can be administered in IV form if needed to be for prevention of stress ulcers, possibly in the hospital. You'll see this a lot. Long-term use of these could lead to community-acquired pneumonias and GI infections such as C. diff. So we have to be careful with long-term use of those. But they're a good drug for acute exacerbations of a severe GERD. Just quickly going to mention oral cancer. Oral cancer is typically, risk factors for that is typically alcohol and tobacco use. It's important to do self-exams and have your dentist exam your mouth for any suspicious areas that could indicate an oral cancer. The prognosis is much better if it is identified and treated early. That's any sore that doesn't heal in your mouth, any place that's a lump that won't go away. Make sure you're taking care of your teeth and cleaning mouth and things like that. That will prevent oral cancer. It can be very serious if it spreads because there are lymph nodes very close in relation to the oral cavity that could allow it to metastasize. So that's the important thing, really, is just to be able to identify and teach your patient to monitor any areas in their mouth that's not healing and make sure they go to their dentist every 6 months and have their dentist check it. This is a picture of the 8-step screening to look for oral cancer. It can be up under your lips, in your gums, under your tongue. So it's important to look in all these places. These are some signs and symptoms: bleeding from the mouth, poor appetite, difficulty chewing, difficulty swallowing, poor nutrition, and that typically occurs when the oral cancer has advanced to where it's causing an impact on the way that the patient can chew up their food and swallow it. Here's a few more slides on GERD, and I've already discussed a lot of these. These are risk factors: obesity, H. pylori, hiatal hernia, pregnancy, again, because it can add pressure to that lower esophageal sphincter. Common signs and symptoms of GERD, again, epigastric pain, coughing, hoarseness. I think we've already went over all of those as well. This is just a review of that. This is just a visual and looking at how that lower esophageal sphincter here can typically, this is a healthy one. This is a one that is in GERD, allowing the backflow of the stomach content up through there. Again, a review of the diagnosis and treatment of GERD, which I've already discussed in the last few slides. So hiatal hernia is more of a structural issue with the GI system that causes a functional problem. It's basically where the opening in the diaphragm, where the esophagus passes from the thorax to the abdomen, the stomach will protrude up through there. Most patients with hiatal hernias are typically asymptomatic, but most of them have symptoms similar to GERD and are treated as they are a GERD patient. There are 2 types of hiatal hernias. There's the rolling and sliding. The sliding ones are the most common. The rolling hernias are typically a little bit more serious as it involves a larger piece of the stomach that protrudes through the diaphragm. This is a picture of a sliding hiatal hernia where this portion of the stomach has come up through the diaphragm. The patient will present with very similar symptoms as a patient with GERD. They'll have heartburn, signs and symptoms of regurg, epigastric pain, dysphagia, belching, feeling of fullness after eating, feeling like something stuck in there after eating, and it's worse when they're laying down. And essentially, the sliding hiatal hernia will cause a regurg, just like GERD does. It'll cause like a backflow of stomach acid into the esophagus. So they have very, very similar symptoms. So they'll treat them with the PPIs and the histamine blockers just as they will GERD. If that isn't effective, we might have to do a little bit more extensive testing, such as a barium swallow. It's the most specific diagnostic test for identifying a hiatal hernia. Rolling hernias are usually visible on looking at that test as they swallow the barium as it goes down. Sliding hernias can be observed when the patient moves through a series of positions and changing their intra-abdominal pressure, so they'll have them lay back and to see if that's what's the cause on a barium swallow. Sometimes they might have to do an EGD, that's where they take the scope and look down if the barium swallow is inconclusive. But typically the barium swallow is a test that they'll do to identify a hiatal hernia. They'll try to manage them medically, like I said, with the PPIs. And then if it's someone who has maybe more of the rolling, the more severe type of hiatal hernia, surgery might be indicated. Surgery that might be indicated for a patient with a hiatal hernia is a laparoscopic Nissen fundoplication. It's a minimally invasive surgery commonly used for a hiatal hernia. Basically, the surgeon will try to wrap a portion of the stomach fundus around the distal esophagus to anchor it and reinforce the lower esophageal sphincter. So it just kind of pulls it back down and tries to anchor it there so that the stomach doesn't keep protruding up through the diaphragm. Nursing priority post-operative for an LNF is to monitor for signs and symptoms of bleeding or infection, and then also make sure to maintain their airway and to maintain their nutrition. There's a table in your IGGI book, post-operative instructions for patients having laparoscopic Nissen fundoplication, talking about staying on a soft diet for about a week. They're going to remain on their anti-reflux medications, such as their PPI or histamine blocker. They shouldn't drive for a week after surgery, no heavy lifting, wash incisions with just soap and water, and report any fever of 101 or greater. So make sure you maintain that airway by keeping their head of their bed up, making sure they don't try to eat large meals right away, because they might not be able to swallow just yet. And then they might have an NG tube. Make sure you understand how to maintain an NG tube. You're going to check placement frequently. Make sure that it doesn't get dislodged, and make sure that it is patent, that it doesn't get clogged. Check it every 4 to 8 hours for proper placement. Should be properly anchored so it doesn't become displaced. Monitor for patency. If it gets clogged, it's not doing any good in there. You're going to carefully observe them as they take their first oral feedings in to make sure that they don't have any trouble swallowing, things like that. And then they're going to have to follow up afterwards and to make sure that the surgery was effective. Esophageal tumors can occur. They can be benign, but most are typically malignant. They usually occur in the lower portion of the esophagus, the distal third end of it. They typically are in relation to tobacco use and alcohol use and obesity. Untreated chronic gastroesophageal reflux disease can be a precursor because it's an extensive irritation to the esophageal wall. Barrett's esophagitis is a exposure to the acid and pepsin, which leads to a replacement of normal distal squamous mucosa with something like a columnar epithelium, and that's in response to the continued tissue injury. These are precancerous cells. Typically, the patient will present with some GERD symptoms. They'll present with a weight loss, having difficulty swallowing and feeling like things are getting stuck in their abdomen. Typically, it's diagnosed after other factors are ruled out. Your patient or your book has some key features of esophageal tumors listed: chronic cough, hoarseness, anorexia, nausea, and vomiting. They may have a barium swallow initially to determine what the problem is in their esophagus. The margins of the tumor might be seen. The more definitive diagnosis is going to be made by esophageal ultrasound with fine needle aspiration. So basically, they're going to do a biopsy. An EGD might be done to inspect the esophagus and obtain tissue specimens as well. PET scan might be done to identify any metastatic disease related to the tumor itself. Here's some pictures of esophageal carcinoma and exactly kind of where that would be and start to grow and start to block and make a person feel like they're having some reflux disorders. Again, here's those key features that I mentioned earlier of esophageal cancer. We already discussed the assessment data and diagnostic testing. Surgical versus non-surgical, it's really going to depend on the malignancy and how much, if the tumor has metastasized, what grade it is, what stage it is. Non-surgical is going to be chemo and radiation. Surgical management might be if they need to remove the tumor, and that can be an extensive surgery. That can be some surgeries that we'll look at on the following slides. So this is where if there's a cancer right here, they're going to have to remove all this part of the esophagus. So they can actually just bring the stomach up here and attach it to the esophagus. That's an esophagectomy. So basically just removing a portion of the esophagus and pulling the stomach up. A couple other procedures that can be done, but they're pretty extensive surgeries. Typically, cardiovascular is brought in as well because we're kind of manipulating the cardiothoracic area. Very extensive long hospitalization post-operatively due to monitoring the patient for bleeding and infection, monitoring for patency now that we've kind of reattached these organs and making sure that that stays patent. The patient will be NPO for a very long time. An NG tube will be in place, and it's just important to monitor that after esophageal surgery. Monitor them for any signs and symptoms of infection. Monitor them for adequate nutrition, and monitor them for their psychosocial aspect of this as well. Now we're going to move on to disorders of the stomach itself. Gastritis is an inflammation of the gastric mucosa. It's erosive or non-erosive. Acute gastritis is inflammation of the gastric mucosa. It's a result from like a food poisoning. Can be H. pylori after exposure to local irritants such as alcohol, just aspirin, NSAIDs. Kind of more of an acute response to something that we've put into our body. Chronic gastritis is more of a chronic inflammatory process related to prolonged exposures to irritants. Chronic gastritis is one of the leading factors for vitamin B12 deficiency due to the inability to absorb B12. A lot of this can be associated with long-term alcohol abuse, can cause a chronic gastritis. H. pylori, again, like I said, is that bacteria that can grow in the abdomen. It's known to be related to some GI irritation. It's not really known exactly how people get H. pylori exposure. It's thought to be that people who grew up more in a rural area might be more at risk for having it. It can be to pass from person to person, they think. But it's a test that we'll do to determine if H. pylori is present, because we do have to treat it with an antibiotic. Again, prevention of a gastritis is just eating well, taking care of yourself. Don't drink excessive amounts of alcohol and beverages. Avoid large intake of aspirins and NSAIDs. Those are things that irritate the stomach lining, as well as coffee. And foods, very high acidic foods are all things that can lead to an acute gastritis and then eventually lead to a chronic gastritis. The difference between chronic and acute, I don't know what happened to this slide here, it got kind of off center. Acute gastritis is more of rapid onset, gastric pain or discomfort. They could have some nausea, vomiting, some blood, bleeding just from the irritation. Chronic gastritis is more kind of vague symptoms, vague epigastric pain, still can have some nausea and vomiting. And then just a pernicious anemia is indicative that someone might have a chronic gastritis. A person with gastritis is going to need some health promotion. They might need fluids initially if they're having a lot of nausea and vomiting, and might need IV fluids to help maintain their fluid needs. They're going to be sometimes NPO just to kind of decrease the irritation. Don't put anything in there. And then when we do restart PO food, it's going to be bland, nothing that's going to cause irritation. We're going to avoid NSAIDs, avoid aspirin. H. pylori, if it's identified, is going to need to be treated with antibiotics. And we'll talk about that a little bit more with peptic ulcer disease. And then also the PPIs and the H2 blockers can be introduced, as well as interventions for gastritis. A mucosal barrier fortifier can also be indicated here, which is the sucralfate, which is a medication that you can take prior to eating, and it can coat the stomach and protect it from the intake of food, causing it to be irritated. Peptic ulcer is actually when a irritation is so bad that it's actually caused a lesion in the mucosa of the stomach or the duodenum. Peptic ulcer disease results when the mucosal defenses become impaired and no longer protect the epithelium from the effects of acid and pepsin. 3 types of ulcers may occur: the gastric, which is within the stomach, and I have some pictures of that, and then the duodenal, which is in the duodenum of the area right before the small intestine. Stress ulcers are typically in relation to a stress, which is can be a surgery on a patient. They're not as common as the gastric or duodenal. So H. pylori has been found to be a precursor for a patient to have a peptic ulcer. That's a gastric ulcer or a duodenal ulcer usually. And like I said, it's thought to be found more in people who live in rural areas, and that's because it's from contaminated water, they think. And basically, this bacteria releases a substance that causes a damaged mucosa. So we can treat that with antibiotics along with our PPIs and H2 blockers. A common complication of peptic ulcer disease is a hemorrhage. So if the lesion is so bad that it causes a bleed, patient can bleed to death from one of these. So we need to identify any GI bleeding early and make sure we're doing what we need to do to stop that bleed before it becomes too extensive. It's just a visual picture of the gastric ulcer where that occurs from peptic ulcer disease and the duodenal ulcer. The symptoms are a little bit different, and typically it's related to the area that it affects. And I just wanted to kind of revisit the H. pylori. The treatment, if H. pylori is diagnosed that it's present, and that's that the urea breath test can determine if H. pylori is present. You can also do a stool antigen test for it, and there is a serologic testing, which means a blood test. It can also be tested if an EGD is done. They can actually take samples and determine if H. pylori is present. If H. pylori is present, the treatment of choice is typically a proton pump inhibitor with 2 antibiotics. So it's 3 medications required for a patient if H. pylori is found to be present. It's proton pump inhibitor such as lansoprazole, which is Prevacid, plus 2 antibiotics, metronidazole and tetracycline, or clarithromycin and amoxicillin. So it could be, there's 2 choices of antibiotic doubling up. That can be, it can be metronidazole and tetracycline, or clarithromycin and amoxicillin. For 10 to 14 days, they're on these 3 drugs. There's a great table in your book that talks about the differential features of gastric and duodenal ulcers. It's typically the gastric ulcer will have pain that occurs 30 to 60 minutes after a meal. With a patient with a duodenal ulcer, it's typically 1.5 to 3 hours. And that's in relation to where it is. When the food hits that area, it'll occur more quickly after eating than it would in the duodenal ulcer. The other thing is typically there's a lot of things that are very similar about it, but like typically the gastric ulcer patient looks a little bit more malnourished than the duodenal ulcer. Just make sure you review that table. The other thing that's in your book is a great table, common examples of drug therapy for peptic ulcer disease. That table outlines the antacids, the H2 antagonists, the mucosal barrier fortifiers, proton pump inhibitors. Those are all listed in your book in a great table talking about what its treatment is for and what you should teach your patient about those meds. Already kind of talked about a gastric bleed. Most common things that cause it is a peptic ulcer disease. It's that ulcer that begins to bleed. So basically just monitoring a patient. If they have any kind of coffee grounds emesis, like I said, our body wants to get rid of any blood that's in our GI tract, so we will either vomit it up or it will come out in the stool. If it's an upper GI, they usually start vomiting either bright red blood or coffee ground emesis is indicative of a GI bleed. Can lead to hypovolemia, which can lead to a low blood pressure. And just can snowball because that results in poor tissue perfusion as well. Typically, they'll put in a nasogastric tube, and then we might have to take them for an EGD emergently. And we got to get down in there to determine if there's a site, the bleed, that we can actually clip and stop the bleeding. That's the number one thing that we need to do, especially if it's a very extensive bleed. They might need blood transfusion to replace the blood that they've lost. This is just some more of the signs and symptoms. Like I said, the bright red blood or coffee ground emesis. Melena means dark tarry stools, decreased blood pressure, and increased heart rate due to the hypovolemia. I'm going to mention gastric cancer just briefly. Most of them are adenocarcinomas. Gastric cancer is actually pretty rare. And unfortunately, once you see the signs and symptoms, it's hard to diagnose. And typically once you see the signs and symptoms, that means that the gastric cancer is pretty extensive by the time we get any obvious signs and symptoms of it. That infection with H. pylori is the largest risk factor for gastric cancer. Again, all of those things that cause like an irritation, there's carcinogens, the tobacco, the alcohol can put a person at risk for gastric cancer. Processed foods are thought to be a risk factor for gastric cancer as well. Treatment, diagnosis is all going to be related to how much the cancer has grown, what stage it is, what grade it is. And typically, a patient, usually the ones that I've seen very rare cases of gastric cancer, but usually they will already have like weight loss issues. They're unable to gain weight. That's because they begin to have absorption problems due to the cancer. The rest of the slides are some questions and case study for you to assess your learning regarding disorders of the upper GI tract. I encourage you to try to answer them, and then the answers are found in the comment section. And this concludes the lecture presentation for Module 5 for the upper GI tract disorders.